This, I would request, we have very respected Dr. Ramanjit Chioda with us. May I request Dr. Ramanjit to please chair the next session? She's already unmuted. I would request you to please take it over from here. Thank you.
Good morning. I hope everybody is going to enjoy this session because I think we all see children, whether we are looking at primary or secondary diseases in the eye, and quite often the secondary diseases that we see like trauma or uveitis will result in glaucoma as well. So what we hope to do in this session is to tell you that the pediatric eye is different from the adult eye when you're talking in terms of glaucoma of any kind. Specifically, I think we're going to be relying more on, talking more on primary congenital glaucoma, developmental glaucomas, but also a little bit about the secondary glaucomas to say that we need to look after them differently than we do with our adult patients. So to know what the normal is like is probably the best way to start. And Dr. Bhagwat is going to tell us what there is available to us in literature about the normal intraocular pressure in children.
Yes, ma'am. Thank you. So should I start? Yes.
Sure.
Yeah.
We have 2 more minutes. Should we start or should we wait?
We can start.
Okay.
That's totally
Do you think, I think whoever wanted to join would have joined by now, unless Dr. Pandav, anything else that you feel that you'd like to say that is different in children as compared to adults?
Pandav sir, you need to unmute.
These children's eyes are definitely different from adults. They are growing eyes, and not only they are smaller in size or to begin with, or to delicate, and but they are also growing. And so whatever we do, to these eyes, it is going to affect their growth as well as the disease, as well as the procedures sometimes affect the growth. So I think we need to be very careful. The parameters are different. The IOP is different. So I think we need to be more careful, and we need to study this area actually quite separately as compared to adults, so that we can treat them much better. And also the children don't tell you what they have. So, we have to rely more on the clinical examination and clues from examination as well from the history, because they won't tell themselves what problem they have. So I think the responsibility is even higher. So I think in that sense, this session is going to be very useful, especially for people who are practicing glaucoma.
I think we have to remember that, children are going to live for the next 70, 80 years. So there's no question of, controlling the IOP for a month or 6 months. It is the 60 or 70 years that one has to think about. And therefore, it's important for us to know what is the target that we are sort of aiming for and why we are aiming for a particular target. I think we should start.
with this, I would request let's start with Dr. Bhagwat's
Dr. Bhagwat, and then Devang, I'd request you to take over the sort of chairing of the thing.
Okay, ma'am. Okay, ma'am.
So I'm starting now. Okay. Is it visible?
Yes,
no.
doctor.
Your slides are not visible. Your
laptop is visible.
Okay.
The screen is visible. You need to press on the presentation.
You have to share the presentation.
Yeah.
Not the desktop.
So, as the Bhagwat is setting up his presentation, I would just like to introduce Bhagwat. He would be speaking on what is normal IOP in pediatric age group. So Bhagwat is presently working as a faculty in AIIMS Bhubaneswar, and he has worked with us as a junior as well as a senior resident. And Bhagwat?
Yes, ma'am. Actually,
you just have to press your presentation.
No, I'm doing that, but
you not share your desktop. Share it and then do it again.
Okay, I'm again doing.
Now share it again. Share the presentation.
Yeah, you can press share screen and then press.
Yeah, now. Got it?
Yeah.
Yeah.
Put it on presentation mode, Bhagwat.
Yeah, I'm putting. Is it fine now?
Yeah, absolutely.
Good.
Okay. So, respected Ramanjit Ma'am, Pandav Sir, Dr. Devang, Dr. Julie, and all the members. So, as this is important topic, as told by our respected faculty. So, what is the normal IOP in pediatric age group? I will just say a few things. Why it is, whether it is different from adult or is it the same target IOP, or what is the normal IOP? Basically, I will start. So IOP in children age, IOP is still the main risk factor for progression of glaucoma. Accurate measurement of IOP is crucial in diagnosis management, as all you know. And as the visual field testing is often impossible in the pediatric population less than 5 years of old, and optic nerve sometimes not visible through a cloudy cornea. So IOP plays an important role in diagnosis and management. And in babies or small children, IOP measurements are problematic, impossible in slit lamp, and so sometimes we do under general anesthesia. So I've been children, not same age in adult. I will discuss later and throughout my presentation, because it is different in different age group. Because as Dr. Pandav told, the ocular growth occurs since birth to nearly about 13, 14 years, and they have low sclera rigidity. They have elastic sclera. They have different corneal viscoelastic property, like in term of corneal hysteresis, corneal resistance factor, etc. And they have different cecity also from birth, slightly in higher range, especially in congenital syndrome and anomalies. The range increased to 630, 670, 70, 700 like that. And so this is different from adult. And what is the exact method to measure the IOP in children? I will discuss on that. And what instrument is the ideal for measurement of IOP? I will focus on these factors. So age told, pediatric eye, child growth, the weight of the eyeball doubles from 3 to 7.5 gram in adult. And the average axial length is 16.5 in newborn eye, and it increases to 22 to 24.5 like normal in approximately after 13 years. So if in a different rapid phase, 0 to 2 years, second phase 2 to 5 years, and third phase is 5 to 13 years, etc. Corneal curvature, you should know that the corneal curvature is not the same 43, 44 diopter in children. It is rather 40 in higher range, like 47, 48 diopter, and it all comes to adult value in approximately as around 3 years, etc. And the infant, the sclera is much more flexible as compared to adults, and the strength is approximately half. And if you see the thickness, 0.45 millimeter to 0.5 millimeter thickness, that is almost half of the adult sclera, that is 1 millimeter. So as I want to say that as some of the parameters, these parameters will depend on the tonometry. The tonometry depends on these parameters. Till now, no tonometry has it is independent of these variables. So definitely the IOP should not be same to the adult eye. And coming to the method of measurement, as you know, the children are difficult to examine. So we do most of the time under general anesthesia, at the term examination under anesthesia. So anesthetic agent depends on the agent. What agent we are using, maximum they decrease the IOP, except some few, and the timing of measurement, because there are 4 phases: just sedations, before sedation, at the time of intubation, deep anesthesia, at the time of extubations. So just after the sedation, before intubation, if you measure the IOP, that is the ideal method. What we do usually in the rapid center examination anesthesia, then you can measure all the corneal diameter, the fundus evaluation we should do. And you should remember that at the time of intubation and the extubation, the IOP increases due to sympathetic overactivity, and the endotracheal intubation is have more effect than the laryngeal mask airway, LMA. So if possible, if we can do under LMA, then that is better. Then endotracheal intubation. And topical anesthesia, the propionate, etc. we use for if the child is slightly cooperative, etc. that is better. And in office procedure like in OPD, etc. you can use chloral hydrate because it doesn't affect the IOP readings. And one important thing I want to speak that we should know that maximum times in examination anesthesia people use the speculum. But if during time of the measurement IOP, if you can use, if you can just spread out the leads with fingers and take the IOP. That will be better, because with speculum it increases the IOP up to 4 millimeter mercury, what literature says. And you can see here, these are some anesthetic agents. Just I'm just focusing on the chloral hydratase, no effect on IOP, and these are all the gases like halothane, nitrous oxide, all the and fluorines, except sevoflurane, they all decrease the IOP. And these are the ketamine, succinylcholine, they increases the IOP. So we should know that what agents we are using, what anesthesia people, what they have used for the induction or sedation. So that knowledge we should have. And coming to the measuring tools, there are many research papers from since 30-40 years. They're using various, they're comparing with all the tonometers, etc. So throughout the literature, what I found, and we have practically experienced, that obturational tonometry is stood amongst all till now the gold standard, even in children, because it is less influenced by the rigidity of the sclera, as only 0.5 microliter of the aqueous is only displaced. So that's why gold appliance tonometry possible is quite accurate and reproducible. Also, if you know that, all it, if used in proper technique, proper way. And indentation tonometry displays large volume, so can be large volume of aqueous, so can be affected by low rigidity of sclera, so causing false low IOP. And tonopen, there are many papers have come with tonopen, etc., because it is very rapid. You can take with children. But tonopen although act as a application tonometry, but however, tonopen tends to overestimate the IOP in infants, so its usefulness in congenital glaucoma screening and monitoring is somewhat limited. And it is not that the intra and inter observer bias are also there, and outside the range they don't work as well like application tonometry. And other tonometry, just to focus, pneumatic tonometry, it is a hybrid technique of application and indentation tonometry. They are usually, if there is scarring of the cornea, irregular edematous cornea. But here again, the repeatability questionable. And there is the impact rebound tonometer, eye care, although not require anesthesia, but again, it is an indentation tonometer, replaces more aqueous affected by the scleral rigidity. Transpalpable tonometry, ProView has come, although has some benefit, but again, it affected by scleral rigidity, thickness of the eyelid, because you do is here the through eyelid, eyelid, and orbicular stone and interpupillary scarring. The newer one, the dynamic contour tonometry, although promising results, as it doesn't dependent on the CCT or contour of and rigidity, but takes that time, like 8 seconds almost in children difficult, and it need to be more practical in children. So among these, what I want to conclude, application tonometry is still now the gold standard for the children. And if you say, what is the IOP of newborn? You say, here you can say, these are the various papers. I have taken this from my International Journal of Ophthalmology 2014. There is a table. You can see this application tonometry, they have run topical. These are all on the newborns only. They are 11, 13 millimeter mercury. But when you see the other researchers, they indentation tonometry 25, 21, again 16. There is a high much variability among these. So still it is more favoring on application tonometry. And just I have taken this from Ijo of Dr. Shiota's article. You can see this is the IOP in adult. Adult, you will see the average. All know that 10 to 21 millimeter mercury, it is just theoretical for the literature of statistical result. But this is 14, 15 on an average, 16, 17, 18. This is the average IOP of adult population throughout this all the study. So definitely the children's IOP will not like that, not will 14, 15, 16 like that. This is from Baker Saffers, that is, they got test for glaucoma. I have taken a table. You can see this Perkins tonometry, they have various in less than 1 year, they have even 5 millimeter mercury, 6, 7, in cases of 13, 15, 16 years. So that means they less than 10, etc., like in the younger kid. And there are many papers, but I have selected one paper to put here because this paper, they work is from RP Center by, again, Dr. Ramanjit, Dr. Deven Tulli, etc., Dr. Tanutada and Binesha. They have taken actually 405 children of 810 eyes they have examined from 0 to 12 years, and through the Perkins tonometry, what they found, the IOP is almost up to 12 millimeter mercury, that is in children. And it tends to approach adult level by 12 years. They got series of that is year wise. they conclude that IOP in children is much lower than the adults. It was not to increase according to age. If there is hyperopia, central corneal thickness, so it changes the IOP. But around 12 is that IOP they found in so much large sample population of newborn to up to 12 years. This was the largest study what I found in literature. And so my conclusion like this, to neonate to 6 months, around 8 to 10, less than 10, I'll say, and 6 months to 12, 10 to 12 years, around 10 to 12 millimeter mercury. And there is a formula in literature I got found. Another formula to up to age 10, you can say that 0.71 into age in years plus 10. That means if the age of child is 3.
I think we get the thing that it's generally 10 to 12, Bhagwat. I think you're overshooting time.
Okay, ma'am.
So
Okay.
I think let's just...
Yeah, I'm just concluding. So 10 to 12 meter is the normal life range of newborn, and IOP tend to get adult level by the age of 12. Goldman applies tournament the gold standard for the assessment with least intra and inter-observed variability. When GET is not possible, Perkins Tonofen eye care can be used in the descending order of accuracy. And topical anesthesia with the speculum, if possible, the ideal. And CCT measurement, if possible, should be done because for the better IOP estimation and correlations. And these are my references I have gone through. And thank you for your kind listening and attention.
Thank you, Bhagwat, for the nice presentation and for letting us know what is normal. So next, I would be just sharing my screen. Is my screen visible?
Yes, Dr. Devang, it's visible. Please go ahead.
Okay.
I think Dr. Devang has a lot of experience with children over the last 8 years. So I think she's going to be able to give us a good idea about the severity of congenital glaucomas.
Thank you, ma'am, for the kind introduction. So coming on to the classification of severity of congenital glaucoma. So once we diagnose a case of a congenital glaucoma, next we should actually classify them, and we should know, because we need to prognosticate the patients, we need to know, tell them what is the long-term outcomes for them, because this is the concern what the parents and the patients they ask for. So coming on to the Hoskins classification, this classification is basically the most followed classification for congenital glaucomas, and this is an anatomical classification which has classified the glaucoma into isolated trabecular dysgenesis, which consists mainly of the primary congenital glaucomas, iridotrabecular dysgenesis, which consists of anterior stromal defects, anomalous iris vessels or structural anomalies, and the iridocorneal dysgenesis, which consists of the Peters anomaly and cases of microcornea or megalocornea. So this classification has its limitation. It does not include cases having systemic anomalies, and it also is not applicable to clear corneas. So that's what was discussed in the World Glaucoma Consensus, where the CGRN classification was proposed, which is the Congenital Glaucoma Research Network classification, which had subdivided the childhood glaucomas as primary and secondary. And the primary, again, they have majorly consisting of the primary congenital glaucoma, which they have given the criteria as patients having IOP of more than 21 millimeters of mercury. Patients with they should have an optic nerve head cupping, which should there'll be an increase in cup disc ratio. There should be either asymmetry of more than 0.2 or a focal thinning. In the cornea, there should the presence of Harp striae or an increase in the corneal diameter, any increase in the axial length or a myopic shift, or the visual field defect. Presence of any, at least more than 2 of these are suggestive of glaucoma according to the classification. And the secondary glaucomas include basically glaucoma associated with non-acquired ocular anomalies, 2B as glaucoma associated with systemic disease, 2C as glaucoma associated with acquired condition, and 2D as glaucoma following cataract surgery. So as you can clearly see that this is again a prognostic classification, wherein the secondary childhood glaucomas are those having slightly different management, and definitely they have a poorer prognosis as compared to the primary congenital glaucomas. So coming on to the next classification. So as we all know that our country as well as the Middle East countries, when the patients present to us, they are mostly in the they are mostly severe forms. And per se, if we search the literature, there are no classification based on the severity of these grading. So Al-Azmi et al. Had very well graded the primary congenital glaucomas as mild, moderate, severe based on the IOP, the corneal diameter, and the corneal clarity at presentation. So if we see, they have defined mild cases as those having IOP less than 25 at baseline, having a corneal diameter less than 13 and a good corneal clarity, and moderate cases as IOP between 25 to 35, having corneal diameter between 13 to 14.5 and corneal clarity fair. And severe cases as IOP more than 35 and corneal diameter more than 14.5 with a poor corneal clarity. So in our center, we had studied the cases of primary congenital glaucomas, and we had included those having at least 5 years of follow-up. And when we looked at their data, we had noted that patients who were presenting with a baseline IOP between 20 to 25, having a cup disc ratio less than 0.6, those patients had a visual field defect which had mean deviation on an average approximately -0.5, whereas the patients who were having IOP more than 30 and having a cup disc ratio more than 0.8 had a tendency to develop a more severe visual field defect over the time. So that's why it is important to assess the severity of the congenital of the glaucoma when the child presents, because it is important for us to prognosticate them and to follow them up according to the severity to prevent blindness. So to assess the severity, we have to measure the IOP and the optic disc appearance that we normally do. Apart from these, there are proxies to IOP, which are the increase in the corneal diameter, increase in the axial length, the myopic refractive error, the visual acuity, and visual fields. So discussing one by one, again, as discussed, IOP is the most commonly measured parameter, and any IOP which is more than 30 can be taken as a severe case. And in the optic disc appearance, any disc which has a diffuse rim narrowing or a cup disc ratio more than 8 can be considered as severe, and any asymmetry also should be taken. Next is the increase in the horizontal corneal diameter. So in the cornea, we have presence of half striae and increase in the corneal diameter. So any dicorneal diameter more than 13 mm can be taken as severe. And the presence of a diffuse corneal edema, it again is a proxy that the IOP has been persistently raised, which has led to the corneal edema, and hence these cases have increased IOP over time. So these cases are more severe if we go back and examine them once the corneal edema reduces. Next is the increased axial length. Patients presenting with an increased axial length usually have, again, is a proxy that the IOP has been elevated, and they usually have a more severe disease to present with. Lastly, the visual acuity and the visual field defect. Once we see changes in the structure, definitely there are damage to the function, and the visual field defect, as we classify in the adults as per the Hoda-Parrish-Anderson criteria. We can define the visual field defect, and depending on the changes in the visual field defect, we can classify them as mild, moderate, and severe. So to conclude, what we have seen over the long term is that the patients who are presenting to us with less than 1 month of age, that is a neonatal primary congenital glaucomas, they are having a worse outcome on the long-term follow-up. Patients having a baseline IOP more than 30 millimeters of mercury also had severe and more worse long-term outcome. And lastly, that unilateral involvement also we have seen the visual outcome is worse bilateral involvement, but this is mostly because of the amblyopia management that has to be taken care of. And I would like to conclude. Thank you. Thank you for the patient listening.
Thank you, Dr. Devang. So I think basically a lot of the time we are not able to see the optic nerve. So which is why Al-Hazmi et al. Had not included the cup disc ratio as part of their classification of severity. But I think now as children come to us earlier and earlier, there are many patients who do come with clear cornea. So it is important for us to know that a normal intraocular pressure of say 10 to 12 in a child can be achieved, nowadays with surgeries and medication. But maybe in children who have a 0.8, 0.9 or an almost total cup, maybe we would try and bring it on the lower side. That means more towards 10. And in other children where it's 0.3 or 0.4, the estimation of severity would allow us to say the target IOP can be even 14 or 15, and we can follow the patients up. Thank you so much for the talk. I think the next speaker, Dr. Devang.
Ma'am, next speaker, I would like to invite Professor Ramanjit Sehota. Ma'am would be speaking on possible target IOP in children, and ma'am needs no introduction. Ma'am, over to you.
Thank you. I think a lot of my talk has already been taken by Dr. Bhagwat and Dr. Devang, so I'll rush through it. Basically, the idea of this talk was to say that, children come to us when they're a couple of weeks old, but they are going to get to be 20, they're going to be 40, they're going to be 60 years old. So whatever we plan, we have to think that, this is something that is a long-term solution to a very major problem. And we can't do it on our own. It has to be something that has actually been experienced over time. So whenever we look at literature, we want to know why are we trying to set this target IOP at all. And in children, keeping this longevity in mind, what we want is to start by actually causing a reversal of any damage that may already have occurred. Or if we can't do a reversal, at least to stabilize the optic nerve head. We want the best possible corneal clarity. We want to make sure that the eye doesn't enlarge anymore and we don't end up with people having -20, -24 myopia. We want to stop it as early as possible. We want the best visual acuity, which is not always in our hands because there may be associated developmental anomalies. We also want a very stable perimetry. What we do know and what literature teaches us is that because of the elasticity of the ocular coats, it is possible to return everything towards normality if there's a significant fall in intraocular pressure. So we've gone through the normal IOP, and I would just reiterate that, it tends to be between 10 and 12 millimeters of mercury. There are many differences in children's eyes as compared to adult eyes. The IOPs that these children come to us with are sort of 30 plus. They all have a very large disc size because of the stretching of the coats. They have corneal opacification, very large corneas, very thin lamina cribrosas. There's a huge asymmetry between the two eyes, which leads on to more visual problems once the intraocular pressure is controlled. And as I'm repeatedly saying, the longevity that we have to take care of. What are the challenges? That by the time the children come to us, they already have pre-existing structural damage. I think the large cornea is something that everybody sees immediately, but associated with that, you have a Descemet stare, and then you have some haze. And just the haze is enough to cause a difficulty in visual acuity later. Increased in the axial length, the associated developmental anomalies like iris hypoplasia, aniridia, fundal problems, they're all pre-existing and we have to work around them. We also have to be aware that children actually grow with time, not only as far as their body is concerned, but as far as the eye is concerned. And these age-related changes have to be differentiated from the IOP related changes. So if you have an IOP which is sort of 20 and it's going to cause some sort of increase in the axial length, some increase in the corneal diameter, this is going to be additional to what is happening with normal growth. We also have problems in assessing the functional sort of damage that we start with because we can't assess vision perimetry. A strabismus is a very common sort of occurrence in these patients over time. And when we look at the therapy of these patients, we need frequent examinations under anesthesia. We know that children have a very poor response to medications as compared to adults. There's a difficulty for the mothers to put the drops. They may need additional cataract or keratoplasty. So keeping all these in mind, what have we learned over the years? This young boy up there, he was one of the patients in whom we did a trabeculectomy with trabeculotomy, but without mitomycin. At that time, we were under the impression that a pressure of 20, 21, anything less than that was acceptable. But you can see the high myopia that he has when he has reached the age of 22. On the other hand, this girl we operated with mitomycin C, and you can see that the intraocular pressure is much lower, and she actually has no need for glasses, at least for distance. So the CGRN classification has given us primary, secondary, and other things, but it hasn't said what is the aim of treatment. And most of the papers you will find will be talking of less than 21, except for this one paper, which is quite old, 1999. So again, when we looked at our patients, 174 eyes or 108 patients, what we found was that a cup disc ratio of minus of 0.5 or less than 0.5 could be achieved with a mean IOP of 10. Reversal was seen only in those eyes where the IOP was 6 to 12. Stability was seen between 6 and 12. And anybody who had an IOP of more than 16 ended up with progression. So keeping this in mind, remember that an IOP of less than 15 probably is the ideal that we should aim for, and anything more than 15 would be more likely to cause problems. But just to put it all together, there are preoperative, that are structural damage that has already occurred. That means in the older children, there's the chronic rise in IOP, a very high IOP, they already cause problems to the optic nerve. So that with surgery, all we can do is lower the IOP, and this lowering of the IOP actually can reverse a lot of the cup disc changes and also reverse to some extent what is happening with the axial length. So visual field effects, what we found was that they were much better in patients who had less than 15 millimeters of mercury in the long term and worse with more than 15. And these are many studies that have been done around the world, which say that if you look at 19 to 22 millimeters of mercury in children, you will find there's no reversal or actually progression. And a similar kind of thing can be seen with refractive errors, that the mean refractive error, if we kept the IOP less than 15, was -2, as compared to, as I said earlier, when we were thinking 20 and 21 was good, supported by a lot of studies, including from Dr. Mandal, you can see is fairly high. So I think we have to be aware of what our target IOP is, and it should be less than 15, but also dependent on the cup disc ratio. So if the cup disc ratio is more than 0.8, make it lower, and if it's only 0.7. Similarly, with secondary glaucomas, you must lower the IOP to at least the age normal, and less if the optic nerve is significantly damaged. I'm not sure why that timer is going off.
I'm so sorry. I'm so sorry, Dr. Ramanjit. There was some technical error. You please go ahead. I'll take care of it.
All right. Okay. So if I can go back a couple of slides, I think most of our surgeries are actually now much more successful than they used to be. So I think we can reach these. So just a little bit of emphasis on the secondary childhood glaucomas, because they are fortunately, a lot of them are iatrogenic because of the steroids we give, because of the surgeries we do following trauma or following a corneal infection. So a high index of suspicion for a raised IOP, early diagnosis of the raised IOP, and a control to normal levels would prevent any optic nerve head damage at all. So if you find that the medication is not allowing you to reach the requisite IOP, you must control the inflammation, think about the fibrosis that has already occurred in an eye like a traumatic eye, and operate only on a quiet eye. Lower the IOP, as I keep saying, to the age normal, and if the optic nerve is significantly damaged, to lower than the age normal. Always evaluate the fellow eye for glaucoma, because secondary glaucomas occur in eyes that are predisposed. So just a couple of cases. This is a child with primary congenital glaucoma. We operated at 1 month of age. The child is now 18, and you can see the review IOPs have been consistently between 10 and 14. And our OCTs, our HRT, and the fundus shows us that the neuroretinal rim is absolutely normal, and these fields in both eyes are absolutely normal. But because there was a difference between the right eye and the left eye as far as the stretching of the cornea is concerned and the axial length, there is an anisomotropic amblyopia. This is another child with axon field rigors. Unfortunately, came to us very late, so we only operated at 11 years of age, by which time, as you can see in the left eye, there's already a significant damage to the neuroretinal rim inferiorly. You can see the damage on the OCT, you can see the same damage on the HRT, and this is her visual fields. But we have an IOP now of 10 millimeters of mercury, and I think that should actually stabilize the optic neuropathy and prevent any further progression. So the appropriate target IOP has to be maintained lifelong. If we want to get clear corneas, very low myopia, and a reversal of the cup-disc ratio. And as I said, these days our surgeries are much better. They are safer. We have more medications available to us. And I think this is definitely a very strong possibility in almost all children. I'd like to thank all the people, as you can see, this entire team from RP Center for all the studies that we have done. Thank you.
Thank you, ma'am, for such a wonderful talk. It's always a pleasure to listen to your presentation and always enlightening all of us, and again, for our residents also. Next, I would like to invite Professor Pandav, and sir would be speaking on achieving the target medical and surgical therapy. So sir is a professor and HOD in PGI Chandigarh, and all of our residents do know sir. And sir is basically known for his very soft-spoken nature. And sir, I would like to just make a small request that if you could be a bit loud for our residents, it will be useful. Over to you, sir.
Thank you, Devang. And thank you, Professor Ramanjit, for including me into this program.
I think, Dr. Pandav, you have to come a little closer to your...
talking about achieving the target IOP, in using medical and surgical management. So we have already heard the importance of target IOP and where it should be roughly in case of children. But how do we get this? There is, we have a number of options. We have medical treatment and we also have surgical option. But pediatric glaucoma, congenital glaucoma mostly is surgical condition. So the medical options are only when you are waiting for the surgery, or somehow it's going to facilitate your surgery, like it clears up the cornea temporarily so that you can go in and do a definitive procedure. Or you could do, you could use it, post-surgery, because if the IOP is still not controlled and you planning to do something else, or adding 1 or 2 drugs if the pressure comes down to your target IOP somewhere around 15 millimeters of mercury. If the surgery has already failed, you have no option but again to go back to medicines. And if sometimes the surgery is too risky or the eye is already blind and you don't really want to do any surgery. So there are a number of situations still that you would like to do medicines, but having said that, management is mostly surgical for congenital glaucoma. So what drugs you can use it? Most of the drugs, can be used theoretically, but they have their side effects, and more so in children. So children, in the tolerate the carbonic anhydrase inhibitors quite well, but you have to be mindful that sometimes you could have a metabolic acidosis because the body weight is small. So even 1 drop actually, you go by body weight, is a large dose for the children, especially in the neonates. And there may be some concerns of growth retardation. Pilocarpine and prostaglandin similarly can be used. Pilo is not generally used much, but it can be used if nothing else is working. Beta blockers are effective in reducing intraocular pressure in children, but then you have to be careful that they do induce bradycardia, and sometimes they can lead to apnea as well. Brimamine is best avoided in children because it crosses the blood-brain barrier and can lead to severe CNS depression in children and could be dangerous. So with that, we'll come down to the surgical management. We had a number of options: trabeculotomy, goniotomy, GAT, trabeculectomy, with trabeculotomy, or trabeculotomyces, and even tubes are an option. So when the cornea is not clear, you have to have an external approach, where it could be a trabeculectomy or combined trap could be done. So this video is a small child, 23 years old, which I operated actually in 2002. So there's a very old video. Essentially, what you do is you create a, like trabeculectomy, you create a limbal or fornix-based flap. In this case, I use a limbal-based flap, and you dissect out the triangular scleral flap. And once that is done, you have to identify the scleral bed, identify the area where the slabs canal is likely to be there. So there's a junction of the gray and the white zone. And once you are there, you carefully, made a radial cut. So dissect identify the Schlemm's canal there. And when you reach the Schlemm's canal, you will, some fluid will start oozing through that. And that would be, like you can see some fluid is coming now. Can you see in the video? So you have some fluid started coming. So we have actually opened up the Schlemm's canal. So you can open it a little more, and you can make some, you can see the fluid is now nicely coming. It should gradually come. It should not come as a spurt. If it comes as a spurt, then you have entered the anterior chamber. So you can, you can slice it radially just to make space for to enter your probes. And then we use the Harms probe, and once it's done, so you can put these probes into the Schlemm's canal. And gently you bring it in the anterior chamber, and basically you are disrupting the tissue or the inner wall of the Schlemm's canal, and one side, and then you do it on the other side as well. So idea is to get at least 110 degrees of trabecular meshwork, which is disrupted, and the Schlemm's canal is exposed to the anterior chamber. And once that is achieved, we can just close the scleral flap and also the conjunctival flap, and that should take care of it. So again, you have the angle dysgenesis, or if there's an angle, no, if there's a lot of angle dysgenesis, not much of a dysgenesis, then one can use, or the cornea is clear, then you can actually try a trabeculotomy, which is this video. I'll show you a small video of trabeculotomy again. So what you do is you have go through a MVR knife and identify the angle structures, and again try to cut this tissue. When you cut this tissue, the iris will fall back a little bit, and try to do it as much as you can, at least 110, or 2 quadrants. Through single port, you can make multiple ports to achieve a larger extent of trabeculotomy. So, okay, and the third procedure which we can do is the gonio-assisted transluminal trabeculotomy for these. So this is a 360 degrees trabeculotomy basically. So what you do here is that, you take a little, proline suture and make the end a bit bulbous. Under anesthesia, then you have to make, with MBR, make a port at convenient position, usually where you are sitting, constrict the pupil with the pilocarpine, and then you have to make another and inject some viscoelastic to maintain the anterior chamber. Then you make another port through which you will insert the proline suture. And once proline suture is inserted, you with a direct gonioscope, now we can create a little opening in the trabecular meshwork. So Schlemm's canal is exposed, and when that is done, this proline suture is then you grab the suture with the forceps, and then it is threaded into the Schlemm's canal. So it goes, round and round, and it will go 360 degrees. So you wait for it to come back to from where you started to the same incision. It will show up there. And once that happens, we grab it with the forceps, remove the gonioscope, and just pull the thread out. So this is going to rip the trabecular meshwork 360 degrees. So it's like doing a 360 degree goniotomy. So these very gratified result with these procedures, because here we are, except for the avexitron or trabeculotomy, when you're doing it goniotomy or GAT procedure, you're not handling the conjunctiva, so that leaves scope for the subsequent surgeries as well. So the up to 80% results, success rate has been reported at under 2 years of age, but after that age, the goniotomy and trabeculotomy doesn't perform that well. Advantage with 360-degree trabeculotomy or GAT-like procedure is that you could end up with the 80 to 90% success rate, and there's no need to repeat because we have already removed 360 degrees. And if it fails, then you have a conjunctiva which is intact for subsequent surgeries as well. So trabectomy is kind of a newer procedure. It has not been much tried in children, but Cahook's blade, cutting off trabeculectomy or trabecular meshwork with Cahook's blade has been reported and perhaps could be used in children as well. Again, if these procedures not fail or we are not doing it, then we have our gold standard, or in the what its procedure to fall back on is a trabeculectomy. And trabeculectomy with mitomycin or without mitomycin can be done. But if we are doing it with mitomycin C, the results, the success rate is higher, and you can get lower IOP. So that will meet your requirement of the target intraocular pressure. And also, you can see this patient, you have a half striae, but the cornea is now clear, has undergone trabeculectomy, has a nice diffuse web, and the IOP is well controlled. 60 to 80%, 67 to 87%, and 1 year results have been reported with this procedure with trabeculectomy with mitomycin C. But as you know, that the failure rate kind of increases with the increased follow-up, so that we have to keep in mind. And all these patients, whatever procedure has been done, they have to be followed up very meticulously. If all these procedures fail, then we have tubes for these kids, and though they are not the first line of therapy, they are kind of and towards when we've exhausted other means. So AGV as well ADI can be tried in these procedures. We have ADI. ADI is like a wearable implant. So AGV is a valve device, where ADI is a non-valve device, which is cheaper than ADI and is easily available in India. So if you look at the prospective randomized studies with Ahmed implant and TRAB with mitomycin C, they quite kind of now this is for cases which are quite intractable. So here the Ahmed appears to be the tube surgery appears to be doing better than the TRAB with mitomycin C in terms of success rate as well as in terms of complications. And this is our own data on ADI in children with refractive glaucoma, not necessarily primary congenital glaucoma, but the pediatric age group, and where we have used Arvind aqueous drainage implant, and you can see the IOP is significantly drops from preoperative to almost there's sustained decrease in IOP for up to 2 years follow-up that we had. And if you look at the survival function, again, even the primary congenital glaucoma as well as secondary congenital glaucoma, in both cases, there's a significant drop in IOP. The IOP remains controlled well in both both these conditions right up to 2 years. So I think in cases where nothing else is working, the tubes, they are a good option. And if tubes are not there, then probably we have to go to the cyclodestructive procedure, but that's kind of in the last. To summarize my talk, managing pediatric glaucoma is a challenge. IOP control requires persistent efforts, and we have a multimodal therapy because no one mode of therapy can give you 100% results. So you have to be well equipped in dealing with the different situations, and we work with different procedures which might be required in children from time to time to control intraocular pressure. And not only that, management also requires other problems which come up with time, like refractive errors, amblyopia, and there might be corneal transparency issues. So all those things need to be kept in mind while dealing with children. Thank you very much for your attention, and thanks again for the invitation to participate in this program.
Thank you, sir. Thank you, sir, for a wonderful video-based talk. I think there are 2-3 questions for you, but I have got a request from the management that the discussion should be taken after after the keynote. So I would be keeping all those questions for you, sir. Thank you, sir, once again. Next,
I think we could take a few questions. We have lots of time. I think
Okay.
they rushed me through my talk, so
Ma'am,
we have a few questions, time for questions. So let's take one or two before we get to the rehabilitation. So
okay, ma'am, should I ask one
yeah, sure,
question
yeah,
that was asked to you, or should I one that has after your talk it had come? So one resident has asked, do we base our diagnosis basing on the corneal diameter and symptoms for patients presenting with IOP in the range of higher teens to early 20s?
as I said, basically we are talking in terms of multiple sort of clinical features. Corneal diameter is one of them. Baseline IOP is the second, and the optic nerve, if visible, is the third. So keep all these in mind, and remember that once the cup disc ratio gets beyond 0.8, the likelihood of reversal is much lower, and it needs much lower intraocular pressure. So all I would say is that, keep that in mind. Corneal diameters, we can't do very much about. We can't do very much about whatever the baseline IOP was, but we can do something about the optic nerve that we actually see. And using that as a criteria, we should remember that, though we are saying IOPs of between 10 and 14 are childhood IOPs, probably 14, 15 is okay for those with a 0.4, 0.5 cup, but 10 or 12 should be what we are aiming for in patients with a larger cup disc ratio.
Okay, so the next question that has come is for Professor Pandav. Sir, the question has come that when do you decide between a limbus-based or a fornix-based flap? Do you have any preference?
No, I think both can be done when we are doing a trabeculotomy, because we are not aiming at a bleb formation. So if you're doing a phonics base, it's easy. The approach is easy, and you're not aiming at a bleb, so there's no risk of leakage at the limbus. But if you're doing a combined procedure, trabeculectomy and trabeculotomy, like many people used to do, there you have it. They have to be careful that it should not leak at the limbus in the postoperative period. So again, it's a surgeon's choice. Most people, I think, they have moved to phonics-based flaps. I think, but I used to do limbal-based flap earlier for pediatric group particularly. Now I do for phonics-based as well. So I'm doing more adult now, less of pediatric. So I'm more into phonics-based flaps. But I personally feel that limbal-based flap for children would be a little better option.
Yes, this was I think we also follow the same. And I would also like to say that the leakage, what we have seen, is definitely lesser when we do a limbus-based flap, especially in the pediatric age group. So the next question is, when do you decide, like how do you choose to operate onto your patients of doing a goniotomy or doing a GAT, or like how do you choose on two surgeries? What would you do?
I think if the cornea is clear, I think the preference is to do an angle-based surgery. So goniotomy would be preferable, goniotomy or GAT basically. But that requires your angle should be clearly visible, so that the cornea has to be clear. So if your cornea is clear, then the goniotomy is much easier procedure to do. I think most of the time we do goniotomy only. GAT, we have just started using it. It needs a little bit of a learning, there's a bit of a learning curve is involved in that. And also you have to be because more manipulation is required in the anterior chamber. There's a lens there also, so you don't want to injure the lens and create cataract. So you have to take precautions there. So goniotomy in that sense is much simpler to do, and but only disadvantage because you are only disrupting a limited amount, maybe maximum is you can go is in 2 quadrants. If you're doing, then you can go to 180 plus, maybe up to 200, but you can't really get 360 degrees. But with the GAT, you can do 360 degrees. So there's that advantage. Other advantage is because you're not disrupting the conjunctiva. So that's another big advantage. But cornea is not clear, then you have to do it externally, which could be a trabeculotomy or a trabeculotomy and trabeculectomy. So corneal clarity decides whether you're going through the anterior chamber or going from outside. And when you're going through the anterior chamber, whether you want to do goniotomy or a GAT, it again is your experience basically and comfort with the procedure. The first one is much more, standard, much more literature is there, and much more easier to do.
Sir, one more question, sir. Apart from corneal clarity, would you consider the cup disc ratio or the severity with the patient that presents to you, your management, or you would go ahead and do the procedure?
I think, like Professor Raman said, I think IOP requirement for kids is actually lower, but still we do, I like to do a angle-based procedure first. And if it doesn't work, then you have an option of doing the external procedure. But as far as possible, if we can do an internal procedure, that we prefer it.
I think we'll go on we're being reminded repeatedly.
Yes,
Let's go to the last presentation.
I would like to invite Dr. Julie. Dr. Julie would be speaking on counseling and visual rehabilitation. Dr. Julie would be putting her slides. I would like to introduce her. She is basically a consultant in glaucoma services in Shroff Charity, and she has been working in glaucoma, I think it's more than around 10 or 15 years. And she has quite a lot of experience in pediatric glaucomas also. And it's a pleasure to invite her. Dr. Julie, over to you. Dr. Julie, are you there?
I guess she's having some internet problems.
Yeah, your voice, we can hear you, but your voice is breaking in between.
Dr. Julie, I would request you to stop your video once. Dr. Julie, can you hear us? She dropped out because of some technical errors and some internet glitches, I guess.
Okay, so should we wait? I'll just...
Should we give her a minute and see whether she joins back? Yeah. Otherwise, we could go on to the keynote and then come back to
for a minute. And
we can ask, I mean, are there any other questions that there were?
I need to check. Meanwhile, Bhagwat, if you have any question, ask if you have. And ma'am, I'll just check the question box.
I can see there's one question, Dr.
One question.
Yes.
The target IOP of less than 15 millimeters mercury, is it corrected IOP for CCT? I think Dr. Nidhi is asking Dr. Ramanji.
Yes, ma'am.
I think that as far as we are concerned, basically it's the correction in children becomes a little bit difficult because half of the corneal thickness in patients with congenital glaucoma is the edema. That you can get corneal thicknesses of 600, 650, but a lot of it is edema. So correcting IOP in children is a little bit more difficult than in adults. But if you can control the IOP and the pressure is now, I mean, the pachymetry comes down to 500 or 550, then I think we could consider corrected IOPs. But in the presence of corneal edema, the correction factors don't actually are not valid.
I think applying correction factors is even difficult even in adults also.
Absolutely.
There is more uncertainty. But still we should know the corneal thickness, because I remember seeing a couple of patients. They came with the clouding of the cornea and some photophobia, and they were referred as a congenital glaucoma. The cornea thickness was 600 millimeters. That was 600 microns. And the disc was normal, the macula was, and there was a little, that basically storage disorder the patient didn't have congenital glaucoma, the patient has storage disorder. So sometimes I think if you know the corneal thickness, that could help you in other ways also.
Yes, yes, absolutely. I think it also helps you to determine how good your control of IOP is, because you control the IOP and the corneal edema settles down, but it settles down gradually. So by the time you actually wait for the clarity in 6 months or 9 months, you can actually use the CCT as a surrogate to tell you whether your IOP is actually doing well or not.
Okay, now Dr. Julia is connected.
Yeah,
your screen. Yeah, we can see your screen. Yeah.
A very good morning to all of you, and I would like to thank you so much for making me a part of this IC. I mean, it has been very, very interesting till now. So counseling is a very important part of the management, and a good relationship must be developed with the parents, the child, from the time of first interaction, because it's a lifetime association. And we all know that parents are going through a very tough phase, because learning that the child has glaucoma. So we need to be really empathetic and sensitive to the parents, and you have to make them believe that we are one team, and you have to guide them step by step from the management of the condition to the visual rehabilitation. So, so a very good postoperative follow-up is important at this time of the pandemic. We know that it is not very easy to follow up, and even patients come from faraway places. So we should guide and teach the parents to take very good photographs and videos for sharing, which will be very helpful in assessment. Like the child I operated maybe 3 weeks back. So the first week we could see that there was some congestion. In the second week, the congestion had reduced. And in the third week, the baby is doing quite well. And so this daily photograph update really helps us in the management. And I think that we must befriend the child. Like Dr. Ken said, the moment he sees a child with congenital glaucoma, he takes him in his arms. So because children have this very a strong sense of identification through smell, and because like Ramanjit ma'am had always said, it's a lifelong association. So it is very important. I think this point is very important. And we must also remember to reinforce on the parents that a regular and lifetime follow-up is very important, that the child may require multiple surgeries, or the child may require medications, and also the complications of surgery like a thin cystic bleb, or development of endophthalmitis looms large always. So I think a good follow-up is very important. The genetic counseling is also very important. We have to draw a pedigree chart and and determine the inheritance patterns and calculate the chances of recurrence. We have to provide them that genetic testing is possible, and also we have to address the role of consanguinity, because that is a big role that plays in the occurrence of PCG. And we must also offer preconception and prenatal counseling, and the role of biobanking. So visual rehabilitation in primary congenital glaucoma is one of the most important part of management. So we know that the children of PCG may have moderate to severe visual impairment. So like myopia is the commonest refractive error that is seen. That is because of the increase in axial diameter of the eye as a consequence of high intraocular pressure. Like in the study, we have seen that more than 30% of the patient had myopia of more than 4 diopters. And in this study also, 2/3 of the eyes had at least 3 diopters of myopia and 2 diopters of cylinder. And that is, the cylindrical number comes because of the unequal expansion of the anterior segment, the corneal irregularities, the corneal scarring and opacification, and sometimes by the dislocation of the lens. So a cycloplegic diffraction is very, very important. In infants and uncooperative child, retinoscopy is performed on anesthesia or sedation. So refractive correction should be given to the children as soon as possible. And if there are embryogenic risk factors, then we must go for embryonic therapy immediately if the child has vision potentially in that eye, or otherwise we may assess for visual improvement in 4 weeks after correction and then go for the embryonic therapy. So you prescribe glasses in the AIO guidelines. So it has been found that children, where there's corneal opacity and half stria, there is a great deal of high order aberrations, and that may cause stimulus deprivation and myopia. I mean, the role of Pros lenses have not been documented ever. This kind of lenses are used in patients with keratoconus and where the ocular surface is bad in ocular surface disorders in children. But in glaucoma, it has not been seen. So full emmetropic correction and very early prophylaxis and treatment for amblyopia with a close follow-up, I think, is a very important part of the management. And in children who have got bilateral corneal opacities which are dense enough, I think an optical pentary keratoplasty has a very good role. Like in this child, the left eye, after doing a trapezoid strap, the cornea had cleared, but the right eye had corneal scarring for which a PK was done. And in child where the vision is low vision intervention should be done to maximize the use of residual vision. So low vision is defined as if the best corrected visual acuity in the better eye is less than 6/18 to 3/60 with a visual field of less than 20 degrees, and blind if it is less than 360 to no PL. According to the IC10 definition, if vision is equal or better than 680, it is called as mild or no visual impairment. If it is equal or better than 660, it is moderate visual impairment. If it is equal or better than 360, it is severe, and otherwise it is if it is 160, it is called as blind. So we have various optical devices for distance and near, like telescopes and magnifiers. I made two small videos, so which I like to share. There are a lot of non-optical devices also. So spectacle magnifiers are commonly prescribed with base in prisms, and the magnifiers can be handheld also. You can give illuminated and non-illuminated. They're like stand magnifiers. And the other optical LVDs are like bar reader, dome magnifier, chest magnifier, penhole magnifier. So I'll just play the video.
These are different dome magnifiers which is only used for reading purpose, especially given to pediatric group. These we can give to preschool going children. You can just use your head up to the dome magnifier. This is a 50 mm dia, and this is a 80 mm dia, the largest one, and this is the 65 mm dia. It's a 7-inch portable video magnifier, and this is the stand on it. We can use it in any of the companies. It's zooming in, and we can just zoom it out according to the need of the patient and according to the vision. Almost sometimes it's for the better contrast. We can also change into blue and white on blue. Also color. This is a 5-inch portable video magnifier. This device is basically designed for near reading, but we can use this device for distance also. This is zoom out. This is zoom in.
So there are also a lot of telescopes that you can prescribe. We just think this.
This is the max detail classes. It is only used for near and intermediate purpose. Occluding one eye, and then we are asking the patient see where you are having the clearest vision. Again, we'll occlude the other eye. Are we clear? Yes. Ask the patient to see binocular. This is covering the intermediate distance to make the system work. This is a device that you can use for distance working. They are reading in class 7, 8, 9. They are unable to do the board. Once flip devices, if you want to use, you can use. If you don't want to use, you can just flip the device. Use this device distance as well as near. This is a reading cap that you can use for near reading. So like remove the device, put this cap, and then you can focus for this. Is the telescopic glasses for distance. Those visual acuity was 660 to 360. They can use these devices as a target acuity 612. This is a knob that you can adjust your target. This is a medium dark gray filter. It's a wraparound design. We also get it in fit over filters. These are basically clip-on filters. The dark gray filter, and this is the amber filter. These are clips. We can actually put it on any of the spectacles. And we can just use it in this way. Also, when we are not needing this, we can flip it over and see with the refractive correction. Also, when we are feeling as if there is a glaring issue, we can just use it in this. Or yellow tinted filters, we use it for the indoor contrast enhancing filters.
Yeah. So this optical low devices actually they're really helpful in visually rehabilitating these children. Also, you get writing guides like black cards or rectangular cutouts. That increases the contrast and helps the child to write. So a lot of contrast enhancement can be done in the surroundings to help the children have a better quality of life. And it has been seen that with the help of the low vision, the visual impairment had been decreased markedly in these children. So these are the guidelines for the purpose of assessing the extent of specified disability. And if it is more than 40% disability, you get a disability certificate. And there are a lot of benefits that you can get in this category. So even without sight, there's still vision. Braille option is still available with all of us. So I would like to say that we need to be empathetic and kind to the parents, work hand in hand with them. A full emmetropic correction, a very early profile excellent treatment of diabetes are most important. A long-term follow-up is the key to maintain good vision. And low vision rehabilitation is a very important aspect of management of vision impairment and should always be done. Thank you so much.
Thank you, Dr. Julie, for taking us through such a wonderful talk and giving us such a wonderful videos especially for our residents who could actually see how things are being prescribed. So
I think the organizers would like us to have the
Yes,
keynote.
ma'am.
So I think let's have the keynote
Okay.
address.
Yes, ma'am. I would like to introduce the keynote. It is Dr. Edward Wilson. So Dr. Edward Wilson Jr. Is from South Carolina and has graduated from the Clemson University with a Bachelor of Science degree. He has earned his medical doctorate from the Medical University of South Carolina, and he has then done his residency, and subsequently he has worked and joined in the same institute as a faculty. And he is also the program director for the residency training there. And he's currently the chairman there. And he has been recognized with a lot of other awards. And specifically to say, Professor Congdon has received the Asia Pacific Academy of Ophthalmology's highest prize for prevention of blindness work in the year 2009. So can we please play the video of Professor Wilson?
I want to thank you so much for inviting me. And I wish I could be there in person, but I am happy to be a very small part of the All India Ophthalmology meeting for 2021. I'm here to talk about my favorite techniques in pediatric cataract surgery for 2021. Now, first, in infants less than 7 months of age, my preferred and favorite technique is to make 2 paracentesis openings and use an irrigating cannula and the 25 gauge vitrector handpiece to remove the lens in these infants by performing an anterior vitrectorexis, lens aspiration, posterior vitrectorexis, and anterior vitrectomy without ever having to come out of the eye. 1 time in, 1 time out, and tenovicryl to close each of the paracentesis openings. And then I place a SilSoft silicone contact lens on at the end of the surgery. And this contact lens is powered based on a lens constant that Rupal Trivedi and I created for the SilSoft lens. No patch and shield, no subconjunctival medicines. And here's what this same child looked like 1 day post-op. I use aphakic spectacles in these children when the surgery is bilateral. Another favorite technique. These same infants at age 4 to 6 years of age, I go back to place my secondary intraocular lens, and almost always I can place these intraocular lenses in the capsular bag. I open the Somring ring. When you do surgery very early in life, there is new cortex formation that creates a Somring ring. That's actually a good thing because it holds the space. This cortical material maintains the lens capsular bag so that I can place the secondary lens in the capsular bag. Now I use the 25 gauge vitrector after making an initial opening with the MVR blade, and I use that vitrector to make a new opening into the Somring ring 360 degrees. At this point, without having to exit the eye, I turn the cutting port off, use the vitrector as an aspirator, and then remove all of this new reproliferated cortical material that has accumulated within the capsular bag. And I remove this clean it so that it can receive the intraocular lens. At this point, I visualize my new anterior capsule opening, and I place the OVD in the capsular bag in such a way that it brings the new anterior capsule up to the iris. Here the OVD is being placed, and I think you can see with this close-up view in just a second, you can see the new anterior capsule opening. That allows me to use, here you can see the anterior capsule opening, new anterior capsulotomy, and now I can place the lens within the capsular bag where I would like it to be, rather than in the ciliary sulcus, and that allows me to do secondary in the bag implantation. And this is what I do for almost all of the infants that I leave aphakic in early infancy. When placing an intraocular lens, and I start primarily placing the intraocular lens at just above 7 months of age, I use manual capsulorhexis, bimanual irrigation and aspiration, and I finish with my posterior capsule opening through the pars plana. This is my my technique that I think I have the most control. It's okay to use other techniques. This is my favorite. I'm also, of course, as probably many of you are who do pediatric cataract surgery, I'm doing more lenses in older children with a primary posterior capsulorhexis, pushing the vitreous face back with OVD, and then placing the lens within the capsular bag. My pars plana technique is my preferred technique for the younger children, but as the children get older, if I don't think they're appropriate for a YAG laser, then this technique, with or without capsular optic capture, is appropriate. My favorite technique with lens subluxation, with ectopia lentis. The patients I see usually have Marfan syndrome or some other type of progressive lens subluxation. I place both instruments within the capsular bag, aspirate the lens contents, and then turn on the cutter without ever having to leave the eye and remove the capsular bag completely. Then I bring the pupil down, and I've been very happy with the performance over quite a long period of time now of the Artisan Iris Claw lens for these children. I think it performs so much better than traditional angle-supported anterior chamber lenses. And so this really is my preferred technique, and we have now 6 to 7 years of follow-up with many of our children. Since we started using this technique, we gained access to it through the FDA. Now, I know in adult surgery for patients without capsular support that you are now becoming a little bit more accustomed to using other non-sutured IOL techniques, such as the Yamani technique. And this is a case with not enough iris to support an Artisan lens, where I did use the Yamani technique, and it did well. But this is only when the patient doesn't qualify, in my view, for the Artisan aphakia lens. I'm doing much more of IOL exchanges, and that's because in young children, we often leave an insufficient amount of hyperopia, and so they develop high myopia from the expected myopic shift. These cases can be difficult, and I think I've learned to manipulate these lenses out of the capsular bag. There's a lot of fibrosis in these kids, but preserving the capsular bag is paramount. I remove these lenses out of the capsular bag, and in this case, I was able to place the new lens back into the maintained but somewhat fibrotic capsular bag. And again, out of necessity, we're gaining more and more experience with safely removing these lenses from the capsular bag and placing new lenses either in the ciliary sulcus with optic capture, with or without optic capture, or back in the capsular bag as this surgery demonstrates. Now, I also wanted to make a comment about these new, I call them physician-directed medications, rather than relying on the compliance of parents. Now, I operate on children, and the parents have to get the drops in. So anything we can do, anything we can place either intracamerally or here within the lacrimal puncta is an advantage to us. And this is a Dexamethasone Insert being placed in a young child's puncta after surgery, and it will release the drug on a taper that is defined. It releases drug even when the child's asleep. And I find this to be an advantage. Our early results of using this device have been published, and we are now in the midst of an FDA United States trial to gain full approval for this device in children. I also wanted to make a comment about intracameral antibiotics. I would not do a pediatric cataract surgery without intracameral antibiotics. I think that many of us in pediatric cataract surgery were early adopters of this, and regardless of your antibiotic of choice, I think you should use it in children. We are often in the vitreous, we're higher risk, and I use intracameral amoxifloxacin because it doesn't need to be diluted, and that's been my antibiotic of choice. This recent article from 2020 emphasizes the safety of intracameral amoxifloxacin, and they find in children that it is as safe as subconjunctival in children. Now, my many thanks for being a small part of this meeting. I wish I could be there in person, but I certainly appreciate being a part of the program. Thank you.
All right, with that, we have 5 minutes for the discussion, so we can go ahead.
I think we've painted many rosy pictures, but I think we've also got so many problems that we have faced over the years. So I think it would be nice if Dr. Pandav could tell us if there's something particular that he has learned over time and made things better.
I think the important thing is that the kids, they need a special care, and it's better to have a separate clinic for these children, like a pediatric clinic, so that they are looked after. Well, that's number one, because otherwise, if you mix up with the adults, then they're not very forthcoming. They get scared. The clinic has to be very friendly to them, and I think we saw some video how the kids needs to be treated. And secondly, of course, from a glaucoma management point of view, early recognition is the key, and early early therapy is the key. Many of these kids are still present late to us, but now I think awareness has gone around. Anything wrong with the kid eye, children's eye, people are now reporting more and more early. So there's a positive sign. And once they have reported to us, I think a very good clinical examination in the first instance is very important. That could be in the clinic, that could be in the EOA, and then we have to, a set procedure is required basically, to follow through these children. And once we have that done, we have examination anesthesia is required to, look at all the parameters like corneal diameter and how the optic, the fundus is, and also to do, look at for any, actually many of these kids might have associated anomalies as well. So you have an angle dysgenesis. So a proper phenotyping is very important, which would need a good clinical examination, sometime EUA, and also, ancillary investigations. You might have to do some UVM to see how the ciliary body and iris complexes, because the spectrum is very wide. What we are talking about mostly is the primary congenital, glaucoma. So which is a kind of a, I would say the good results are seen when you have a PCG, which typically presents around 3 months of age. But if it's presenting too early, right after birth, that means the severity is more. And if they're associated dysgenesis, you have iris or corneal changes, the severity is more. And they may have different, underlying genetic mechanisms might be there. So we need to identify those phenotypes more carefully right in the beginning, and kind of make a therapeutic plan for them. So
I think Dr. Julie's presentation was also really good, because we get a lot of patients in whom you do find 618 plus vision, but there's a lot of them who also end up sort of 660, 636. And in those, you have to try all the devices she has suggested. Which one works the best, Julie, probably for a 660 vision?
We always try with the spectacle magnifiers, and then we push out to the low vision clinic and see which device the child is best compatible with and comfortable with, and that is the device we prescribe. But the telescope really works, and the magnifiers really work.
I think the telescope is actually a fantastic thing. People who have 3x60 vision, children with 3x60 vision, you give them a telescope, they're reading 618. But the problem is to hold a telescope in the class. They don't want to do that. So I was very interested in seeing this new device that you had, where you can just flip it on the spectacles. So I think this is something that we should all try and find out where it's available. And, we will contact you, Julie, to find out what can be done.
So it's available with us. So all these devices are available at Shroff. So we really send all our patients there, so that a good visual rehabilitation can be done, because otherwise, and to motivate the children to use it also. And
Bhagwat, any thing that you have learned over time that you are now applying in Bhubaneswar?
Bhagwat, please unmute yourself. Unmute.
New thing, not like that. What I've experienced in RP center, the lots of congenital glaucoma management. That means trabeculotomy. I have seen the success with good success trabeculotomy, and after that also your surgery in Indian scenario, trabeculotomy plus trabeculectomy. And if the children comes to early, the examination under anesthesia in peripheral colleges like our colleges. So to get anesthesia backup for a examination under anesthesia difficult sometimes, because we have no such fixed always that we get anesthesia like at the center. So that is the one thing we should do. We should quickly do the examination under anesthesia. Various syndromic, maybe they comes in multi-centric, like big hospital like AIMS, etc. So we are working for that, how to get checked quickly the IOP, etc. All the fundus evaluation. And
I think that is most important, because in a child, unless you get a good baseline evaluation, it becomes very difficult afterwards to say, did you do a good job? Did you actually help the patient improve, or is it just, you've left him where he started off with? I think I'm now getting dirty looks from everybody. So I would like to thank all the speakers and say it was very accommodating of everybody to have a short and very, very informative presentations. Thank you so much. Thank you.
Thank you, ma'am. Thank you, everyone.
Thank you, Dr. Devang. Dr. Julie.
Big thank you and congratulations to all.
Have a wonderful Sunday. Thank you.
Also, I would like to mention here, Dr. Devang, thank you so much for helping us out. Thank you so much, Dr. Ramanjit, and I am deeply apologize for the buzzer in between your presentation. I'm so sorry for that. That was some technical error and nothing to run the presentation or something like that.
Thank you. Thanks.
Thank you so much.